Hi everyone, my name is Jennifer Youn. I'm one of the internal medicine residents from Tufts Medical Center. My clinical vignette is a case report of giant cell arteritis associated with myositis seen in MRI. Giant cell arteritis, short for GCA, is systemic vasculitis of medium and large sized arteries, mainly involving the head and neck. GCA is most commonly seen in adults in Western countries and those older than 50 years of age. Classic symptoms include headache, jaw claudication, and temporal tenderness. Sudden vision loss is the hallmark feature. GCA is commonly associated with polymyalgia rheumatica. It is very rare for GCA to occur with myositis. This case highlights an association of biopsy-proven GCA with myositis seen on MRI. And this brings us to our case presentation. We have a 66-year-old female who was admitted to the hospital with new onset bilateral lower extremity pain. Past medical history included headache, hypertension, and GERD. On admission, she endorsed new onset bilateral thigh pain that progressively worsened over the past 2 weeks. During this time, she also reported fever and night sweats, and over the past year, patient had had chronic bed-like headache. She denied any jaw claudication or vision loss. On physical exam, patient had negative temporal tenderness. Patient did have lower extremity weakness and decreased range of motion on exam. Laboratory data were significant for elevated white count of 19.4, CRP elevated at 303, ESR elevated at 102, and D-dimer elevated at 1950 with upper normal range being 500. CK was 36 within the normal range, and the following are normal, including ANA, ANCAS, complements, rheumatoid factor, and anti-Jo1 antibody. MRI of her pelvis with and without contrast reveals soft tissue swelling in the posterior bilateral hips along the source of the sciatic nerves and bilateral iliacus muscle swelling consistent with inflammatory myositis as seen on figure 1 and figure 2 below with red arrows pointing to the areas of inflammation. Extensive workup for infectious myositis was negative, including HIV, Coxsackie B, TB, toxo, and tick-borne disease. Given her headache for the last year, she underwent temporal artery biopsy. Biopsy showed inflammation in all layers of her arteries and was associated with fragmentation of elastic fibers without giant cells. She was diagnosed with GCA on biopsy and started on prednisone 60 mg daily with marked improvement in her symptoms. Prednisone was tapered and patient was transitioned to tocilizumab. In summary, this case illustrates an atypical presentation of GCA with associated myositis. There has only been one documented case in the literature of occurrence of GCA with myositis seen on MRI. Myositis without CK elevations should raise suspicion for vasculitis. The classic feature of GCA, including the headache, jaw claudication, and temporal tenderness, have negative predictive value in the range of 70s. Although new onset headache in the elderly always raise a concern for possible GCA, headache may be absent in 10 to 15% of patients with isolated extracranial large vessel involvement. In summary, it is important to recognize the atypical manifestation of GCA and association with CK negative myositis. Thank you.